how it grows, all right? And that'll take us about an hour and 10 minutes. And then we'll take a break, and lab will be kind of a mixture of lecture lab on the skull. This morning, we have a little bit shorter class time on Tuesday and Thursday than you do, and then longer on Friday. So we got through about, not quite all of the cranial cavity bones. So your quiz, you have a lab quiz on Thursday, and that will cover the skull won't be on it. So it will cover what I talked about today and what I talked about on Friday. So the parts of the bone, the periosteum, bone cells, and then the stages of bone development. Okay? So the skull that we'll do in lab today will not be on Thursday's quiz. So we have we went over this really briefly on Friday. We have two different types of bone formation. One is how primarily our flat bones are formed. So I have the temple bone up here. It forms part of the side of the skull. You can see how thin that is. All right, so that is one of the flat bones. The sternum is a flat bone. The iliac portion right here is a flat bone. And so those are all formed via a series of steps known as intramembranous. And that word membrane should remind you that it's a flat bone, like a membrane is thin. Okay? The other type of bone formation comes from a cartilage model. And so the best example for this are the long bones. And so the chondro, remember chondrocytes, chondroblasts, that should remind you that this is the cartilage model. All right? So ossification is the secretion of the bone matrix. So when we look at the term ossification, this is what happens when an osteoblast secretes the bone matrix, which is osteoid. For that term, that's the collagen fibers that are unique to bone. They're different from the collagen that we see in skin or the collagen that we see in cartilage, and all the proteoglycans and glycosaminoglycans that we have in our bone matrix. Then, mineralization is a process of adding calcium phosphate, the hydroxyapatite, to the osteoid. And that comes out of the blood, the minerals do. Remember when I drew the collagen fibers like this? And then we add the minerals into this space here? Okay, so the formation of the collagen fibers is ossification. The adding of the minerals is mineralization. Right? And that is unique to bone formation. When cartilage dies, the cartilage matrix, in the process of dying and afterwards, calcification occurs. All right? Any of our tissues can be calcified. Blood vessels can be calcified. It's just a deposition of calcium salts. So when I was in graduate school and I was taking gross anatomy with the medical students, we had our own cadaver, 4 or 5 of us graduate students, and we were dissecting in the abdominal cavity, and there was a blood vessel going to the kidney that was kind of crunchy and kind of large and crunchy. It crackled when you pushed on it. And so we were talking amongst ourselves about what this could be, and I just made up, I thought, a phrase. I said, oh, that's a calcified aneurysm. An aneurysm is a thinning of a blood vessel wall. And then we went on, an ectopic pregnancy, and we were just kind of having fun throwing out different things that this could be. And we called over one of the guest professors, a surgeon, who was helping. And we said, what is this? And he looked at it, and he said, oh, that's a calcified aneurysm. And my standing among the graduate students went way up here, even though I just actually made up the term I thought. So any tissue can be calcified because of pH. If the pH gets too low, that allows the salts to precipitate out. And so this is not a calcification. This is a mineralization. The minerals are deposited there on a particular format. All right. So bone cells involved. With endochondral, we're going to include the cartilage cells first. So do you remember what we call the cells from the embryo that hadn't differentiated yet into mesenchyme? Okay, so both of these are going to start out with mesenchyme or mesenchymal cells. And in the case of intramembranous ossification, the mesenchymal cells are going to develop into two tissues. They are going to develop into fibroblasts. So the purple cells will be mesenchymal cells. And they will develop into osteoblasts. All right? So we're going to see the formation of fibroblasts and osteoblasts. And this occurs in the presence of a very good oxygen supply. So for intramembranous ossification, we need a good oxygen, a good blood supply in the area. So I'll draw in blood vessels. And some of these mesenchymal cells are going to then, here would be a mesenchymal cell, and they're going to form osteoblasts. With the right combination, their genes that make the gene type, the bone type of collagen fiber will be activated, and the mesenchymal cells will develop into osteoprogenitor cells and then into osteoblasts. And so those osteoblasts then are going to start secreting bone matrix, the osteoid. Remember, osteoblasts are mitotic. So some of these will be dividing and forming more osteoblasts, and others will be surrounded by bone matrix. And will turn into osteocytes. And out here on the surface, it will be an osteoblast. So where this first starts occurring is known as an ossification center. All right, it's the origin of this new bone tissue. So even in this little first piece of bone, you can see the bone matrix with the osteocyte extending its process and the canaliculi forming, and osteoblasts on the surface. Okay? So the first piece of bone is one of those trabecules, one of those spicules that we see in cancellous bone. And as that occurs, other cells continue to format, and with the blood vessels that we have in the area, the bone developing cells are going to maintain that as a space. And so we form bony spicules. So this would be a spicule of bone. And we'll have another spicule of bone with a channel around that. And so what we end up seeing happen is we get these bony surfaces with the osteocytes and the osteoblasts on the surface. And also, this will start to thicken and form a collar of bone. And so we start to see a thicker area. At the same time, our mesenchymal cells that were forming fibroblasts become more organized. And we have a dense regular connective tissue out here and and a dense regular tissue out here where the fibroblasts have developed from the mesenchymal cells. And since this is bone tissue underneath it, we call this layer of dense regular connective tissue a periosteum. Okay? Now between that layer of periosteum and the bone, we have additional free surface, so not a free surface, but a surface, so we have osteoblast. And we keep laying down more bone. And then osteoclast, which remember are modified blood cells, so they're going to be brought in by the blood vessels. They're going to remove some of this bone. And then as we lay new bone down, this will move out. And then osteoclast will remove this, and we'll lay down new bone, and osteoclast will move this, and so that flat bone is going to get thicker in this direction. All right? In addition to that, notice these channels as the trabecular bone is formed around the blood vessels. Those channels can be filled in with layers as well. The lamellae we were talking about. We don't see very well developed lamellae in flat bones, but here you can see the periosteum. That is a thin layer of compact bone, and then the cancellous bone. Okay? No chondroblasts are involved in this at all. And we always have blood vessels that are present. So if we go back and look at the characteristics listed here, so there's lots of blood vessels. The mesenchymal cells become osteoblasts, which lay down the bone matrix, or osteoid. That causes those surrounded by the osteoid to become osteocytes. And then we continue to remodel as we thicken. So here would be the spicules, or trabeculae, and here would be the thin layer, but still compact bone. Okay. We call this arrangement of trabeculae inside a flat bone diploid. So we look back at this illustration here of flat bone. So this is known as diploid. There should be two dots over that. And this is where we find our bone marrow now. So as an adult, we continue to see bone marrow, red bone marrow, limited to these areas of the flat bones and then the epiphyses of the long bones. All right, so we never have a perichondrium with this, all right, because we never have cartilage. But we do develop this thicker outer bone here that's described as a bony color at first, and then it's modified to get thicker and thicker and thicker. Notice how in the fibrous periosteum, how even the artist has drawn that as dense regular, and yet our textbooks continue to call it dense irregular. Even in the microscope, it looks dense regular. Okay, so that's what it is. I think sometimes in the textbook industry, something's been around for 40 years and they just keep publishing it. They never bother to go back and actually check it out. All right, so now let's compare that to, we've got a couple of pictures here. So here is the mesenchymal cells out here. Let me just make that a little bit more contrast. That much. So here's the mesenchymal cells, and then as we're getting more compact, they're becoming osteoblasts and laying down these spicules. Here, you can see the osteoblasts on the surface. All right, here are some osteocytes, and this is the new unmineralized bone matrix. It almost looks like loose irregular connective tissue. It's so thin. This is actually known as woven bone. It's because the collagen fibers are almost like the dense irregular collagen bundles. They're not organized into the parallel arrangements of spirals that we saw alternating in the lamellae. So as this bone gets older, osteoclasts will remove that woven bone and lay down the collagen in a more organized fashion. Okay, so this woven bone is normal for new bone, or if you fracture a bone, to break it and it's healing, woven bone is present there as well. Okay? But there are certain diseases where bone, when it's laid down, never gets remodeled. But this is a normal location for it to be that way. All right, now let's look at the second type of ossification, and that is where we have a cartilage model. So instead of the mesenchymal cells becoming fibroblasts for the periosteum and osteoblasts for the bone tissue, when we have endochondral ossification, the mesenchymal cells will become fibroblasts and chondroblasts at first. And they form a cartilage model. So these are going to become fibroblasts and chondroblasts. So let's draw we'll draw a bone kind of like a finger bone. Actually, I don't want blue, I want green, sorry. Starting out with cartilage. So the chondroblasts have laid down a piece of hyaline cartilage, right? So we have chondroblasts out here near the center and larger, older chondrocytes here. So they'll start out as a cluster, just like the osteoblasts did, and grow interstitially to form this model. The fibroblasts develop from the mesenchymal cells, so they lay down a layer of dense regular connective tissue. Instead of being a periosteum, this is a perichondrium. And we have blood vessels. So the hyaline cartilage itself, remember, is avascular. Okay? We don't have blood vessels normally supplying. It absorbs its nutrients through diffusion of the cartilage matrix. But we do have blood vessels out here kind of supplying the perichondrium. And by diffusion, the cartilage matrix. And we have much thicker cartilage than this in our ribs and in our larynx as we get older. All right, but even in the fetal bones, these are their expression of their genes is set up that these cartilage cells, two things happen. These cells start to, in the center, will divide, but then they also start to die. So in their genetic makeup, they're programmed to die earlier than they would in other locations. As they die, the cells, in kind of response to the cell death, get larger, not because they're making more organelles. They just kind of swell up, and they start to get bigger. Okay, as that's occurring and in hastening the process, our blood vessels bring in osteoblasts. And so underneath the periosteum, osteoblasts appear and lay down a thin layer of bone matrix on top of the cartilage. And this is known as a bony collar. It's seen in yellow over here on the diagram. So now, where it lies over the bony collar, it's no longer a perichondrium. It's a periosteum. The tissue itself didn't change. It's just covering bone instead of cartilage. Well, having that bony collar further interferes in the chondrocyte's ability to have a normal metabolic. They proliferate as well as start to die. So we start to see quite a few large spaces And the larger the cells get, the thinner the cartilage matrix is between those spaces. And we call those spaces lacuna. Remember? Eventually, the blood vessels pass through the bony collar, and they have osteoclasts. Remember, osteoclasts are modified white blood cells, and these blood vessels bring in osteoblasts and osteoclasts. The osteoclasts remove the cartilage matrix, so now we have long, empty tunnels inside the middle of the cartilage. And the osteoblasts start to lay down a bone matrix. So on top of the cartilage is the bony matrix. The osteoclasts remove that and some of the cartilage matrix, and the osteoblasts lay down more bone matrix, and the osteoclasts move that, and the osteoblasts lay down more bone matrix. Okay. So starting to see that it's still cartilage, but it's starting to take on that appearance of cancellous bone. Eventually, the osteoclasts will remove all of the cartilage and will have just bone. Okay. So this, in the center of the diaphysis, this process is known as, the location is the primary center of ossification. So while this is occurring in the center, through appositional bone growth, we're increasing the thickness and presence of our bony collar, which is going to be compact bone. And eventually all of this is bone matrix in this center area here. Okay? But we still have cartilage out here. The same process begins out in the epiphyses, where the cells enlarge and die, and blood vessels bring in the osteoblasts and the osteoclasts, and exactly the same process occurs. So we have a single primary center of ossification, and then we have two secondary centers of ossification. Okay. Until we have cartilage present only at the outer portion here, and only in the center. And the rest of this area in here, I'm not going to bother with the bottom one. And the rest of this area in here is trabecular bone. So we have the articular cartilage on the surface of our joint, and we have a cartilage growth plate, which is what you see here. So this would be articular cartilage. It means joint. It's highly cartilage, but articular means a joint surface. So this is what covers the surfaces of bones where they're going to form a joint. All right. And then this region of cartilage is known as the epiphyseal plate. As long as that is present, the bone can continue to grow in length through the interstitial growth of the chondrocyte, the cartilage. All right. So I'm going to show you some images of fetal finger bones, and then we'll come back and look at how the bone grows in length. So notice how we took a cylinder of cartilage, and as the cartilage cells died, the bone matrix was laid on top of the cartilage, and then that was removed along with cartilage matrix, and more bone matrix was laid down. And that continued to occur until all of the cartilage is replaced by bone, except for our epiphyseal plate, and eventually by the time you're 25 or so, even that is then replaced by bone. So the emphasis I want to make right here is that the cartilage does not become bone. It disappears and is replaced by bone. Okay? It's not metamorphosed into something new. It's replaced by another tissue. I'll come back to this in a moment. So here is a developing finger. I'm going to go through a series of slides and show them to you, and then we'll move to bone growth. So even though these are short, they're classified as long bones because they're longer than they are wide. So here you can see the primary center of ossification. This is still cartilage. Do better. This is still cartilage out here, and this is developing into bone. All right. So if we look at that in a higher powered view, or at least another one. So here you can see this darker red is the beginning of the bony collar. This light area here is where the cartilage cells are enlarging as they die. And in this slide, here's the thicker bony collar, and you can actually see that bone cells have started to come in. So the pink, the blue is cartilage, and this pink here is the bony collar. So this would be the perichondrium out here. And so these are the resting, multiplying cartilage cells. Here they're starting to die, and you can see how the spaces around them as the cells are getting bigger. Notice how very little matrix there actually is between the cells as they get bigger. Here there's a break in the bony collar, and I showed this to you on Friday. Here's the bony collar. Here are the collicuna. Here we have cells. Here the cells have died. And you can see we have this long channel here created by a break in that matrix that is so thin. And blood vessels are coming in along with osteoblasts. And so here's the new bone matrix that's been laid down on the surface of the cartilage matrix.
Where's the canaliculus?
Canaliculus, you can't see the lacuna. The canaliculi would be the grooves that the osteocytes have their processes in, and we don't have osteocytes yet. We just have the osteoblasts laying down this new bone matrix right here, okay, on the surface. So it's a mixture of the model is the cartilage that forms the framework upon which the bone is laid, and then we just gradually remove part of the framework and more bone, part of the framework and more bone, and we just keep doing that until all the cartilage matrix is gone. But I want to show you this image to show you how those channels develop. In intramembranous ossification, the channels are developed as bone is laid down around blood vessels that are present. In endochondral ossification, the origin of the channels, in other words, what would be a central canal and our osteon, are from these spaces that were the holes, the caves that the chondrocytes were in. And those spaces enlarged, and then were joined together as the thin wall of matrix is removed. Okay? Now, what that does is it leaves us with a series of zones that we continue to see in the epiphyseal plate. So up here at the top of our cartilage plate, just next to the epiphysis, is a zone of cartilage cells that do not divide. I'll draw this on the board in just a moment, but I want to kind of go over the images with you first. And so these non-dividing cells are known as the zone of resting cartilage or the zone of reserve cartilage. Okay? And they stay that way, they just move. So in essence, what I'm going to describe for growing bone is we have this zone of reserve cartilage. On the deeper surface of it, those cartilage cells will actually undergo mitosis. And as they multiply, they're going to make that zone thicker. Okay? Then they will start to get older, and they will enlarge and get bigger. And then they will die. So every cell underneath the zone of resting cartilage is going to go through these stages. It looks like, well, let me just go through it with you first. So here we have the zone of proliferating cartilage. They're multiplying, and then they're getting larger. That's the zone of hypertrophy. And then they die as calcium is deposited around their matrix, and it's the zone of calcified cartilage. What I'm trying to get across is that these cells right here that are proliferating are going to stay right here. All right, cells above them will proliferate and make that thicker, but these cells, as they get older, will look like these cells. The cells right here that are getting older and bigger used to look like these cells. All right, these cells eventually, as they get older, will look like these cells. So it's a progression. And as here's our zone of resting cartilage, as these cells multiply, that zone of resting cartilage is pushed up. And then these cells will get old and die and replaced by bone. These cells will continue to multiply and push that up. And then these cells will get large and old and die and get replaced by bone. And so the epiphyseal, the leading edge right here just keeps pushed farther and farther apart from each other by the zone of proliferating cartilage cells, chondrocytes, as that gets thicker. So here we have, again, this would be in reference to what I have here, and I'll leave this up as I draw it on the board. We have the zone of resting cartilage. Those are the oldest cells. So they're not dividing, okay? They just stay there. They're just cells. And they attach this epiphyseal cartilage to the plate, to the epiphysis. Here we have them stacked up like pennies. So this would be the zone of proliferation. And then here they're getting larger and bigger. This would be the zone of calcification. You can see how very little matrix there is. Now that the calcified cartilage, the cells are dying, and we see the invasion of the bone cells. Okay? So let me leave that diagram up while I redraw it over here. So this is how we get the progression of our developing bone, and then as long as we have the epiphyseal plate, that continues to be the mechanism by which the bone grows in length. So above this is what I kind of have right here. Above this would be the trabecular bone of our epiphysis. So this would be the epiphysis up here.
That's above the articular
So
cartilage?
I'm drawing this right here.
Oh, okay.
Okay? The epiphyseal plate, in other words. So we would have our chondroblasts here forming the resting zone, or zone of resting cartilage. Resting or reserve. And then the lower edge of that, the cells, the cartilage cells would undergo mitosis. And they do so rapidly that there's very little matrix production. So this now becomes the zone of proliferating cartilage, or zone of proliferation. So as these proliferate, you can see how they would push that reserve zone away from the other end of the bone. And then these cells, there are cells down here that used to be the zone of proliferation, but now they're older and they're dying, and they're going to become larger. These are still living cells. Bless you. So this becomes the zone of hypertrophy. Okay, and if we wait a few more weeks, this zone of proliferating cartilage is going to look just like this. Does that make sense? Because these zones, these aren't going to move. They're there. And these cells will just start to die and get bigger. And these lower cells here will continue to proliferate as that moves that farther. You don't have to worry about that. It's just kind of a continuum. And then as the cells are hypertrophying, the cells are dying, they can't take care of their matrix very well. And so calcium salts, precipitates of calcium start to appear. And that makes it even harder for these to maintain a good matrix. So let me put in the calcium salts. And we have the zone of calcification, or calcified cartilage. Here we start to see the dying, the chondrocytes are dying, and osteoblasts are starting to come in and lay down new matrix on that cartilage matrix. Okay, so once again, this used to be down here. And as the chondrocytes deep to the resting zone multiplied, it created a zone of proliferating cartilage here. And then those cells that look like that started undergoing the aging process and getting bigger and dying and collapsing. And now the bone is being laid on their matrix. These cells right here will eventually, as they get older, will also, the matrix will become calcified. And then these cells will look like this as the bone is moving up in this way, kind of following the plate and replacing the matrix with bone. And so that just continues to happen until our growth hormone levels drop, and eventually all of this is removed by osteoclasts and replaced by bone. Question?
So bone doesn't spread from the secondary centers, only from
Just from
the
the,
middle?
yeah, from the epiphyseal plate. So we form the secondary centers, and then those are just, they'll get bigger as the bone does, but it doesn't move down into that reserve cartilage.
Okay.
So this is always the leading edge, and then the bone follows that.
Okay.
Yes.
What's the last?
The zone of ossification, it's not really cartilage, it's the bone replacing. Okay? So this is the hardest concept in this unit. And what I want you to be able to do is to, within this concept, understand what's going on in the different zones. So where would the youngest cells be? These are the oldest. They're not changing. So the zone of proliferation where we actually see mitosis going on are the youngest. And then these would be the next oldest down here. So the zone of reserve or zone of resting don't undergo mitosis. They just stay there as an anchoring tissue to this bone. It's this first layer up here of the proliferating cartilage where we have the mitosis. These are the youngest.
So these don't ever do anything.
So these don't ever do anything except just attach this to the trabecular bone of the epiphysis. Eventually, when growth hormone levels drop and your epiphyseal plate disappears, yeah, they would be removed. So eventually, this whole process connects. All right. So if we look at question.
Which zone do they die in?
They start to die in the hypertrophying. They die in the calcifying. Okay. It's kind of which comes first, the egg or the chicken?
Yes.
Because the calcification increases their dying, makes it more difficult for them to get metabolic activities, and because they're dying, they can't maintain the pH, and that increases the calcification. So it's both. All right. So as we look at this slide, here we can see that here's the epiphyseal bone. our epiphyseal plate. The bone development has, in that sense, we now have a bone, and the only cartilage that's present is in the epiphyseal plate. If we look at that larger, once again, here's the zone of reserve cartilage right up here at the top. Okay, the epiphyseal bone would be up here. And you can see how those look like osteoblasts. They are, and not osteoblast, chondroblast. And then almost immediately you can see this zone of proliferation. Just a sudden change. These are the mitotic cells. These are the younger cells. These cells right here again used to look like those, but now they're older. They're enlarging, and down here they're dead. And here the pink is the bone coming in and filling in that surface. And this just continues to move as the plates are pushed apart. Again, bone grows in length by the interstitial growth of cartilage. Once this cartilage is gone, this bone will not grow in length anymore. Okay? Bone can only grow adding on to the surface, so it will grow outward like this by adding on to the surface and removing from the inner surface. And that will allow it to grow outward. Okay? Bone can only grow through appositional growth by layers.
Usually we've seen cells die and they get smaller. Why are these getting bigger?
Swelling. Remember we talked about without sodium ATP, affecting the sodium potassium pumps, they can swell up, so that's part of it. All right, so here's two x-rays of a hand, and you can, this is the radius on your thumb side, and you can see a gap. That's not really, it's a gap in the bone, but it's actually filled with that epiphyseal plate. Without the mineralization, it shows up black. There's nothing there to reflect the X-ray energy back. And so that shows that this bone can still grow in length. Here in the metacarpals of your hand, here's another epiphyseal plate, as well as in some of the finger bones. So when my oldest son was, let's see, a freshman in high school, he started his freshman year 6'2" and ended 6'4". He's now 6'5.5". But he was wearing size 15 shoes. And on the catalogs, they don't sell them more than 12 or maybe 13. So we had to special order his shoes. There are certain stores that can find them. But he had a basketball tournament over near Healdsburg. And he had a game at 8 and a game at 11. And 5 minutes into his 8 o'clock game, somebody came down on his ankle. Gave him a high ankle sprain. So we took him to the ER, mostly to make sure he could play the second game. And when the x-rays came out, I looked at his feet, and he still had epiphyseal plates in his toes.
Oh my God.
But those must have closed certainly shortly after, because size 16 is the largest. And now, depending on the shoe, he wears between a 15 and a 16. So my daughter, when she was 11, wore size 10, size 10 and a half. So she's between size 10 and 11 now. Mine are 9 and a half. And so I thought, well, she's going to be tall. Her freshman year, our high school is a parochial church-run high school. For insurance reasons, they don't do tackle football, but both the girls and the guys play flag football. They still tackle each other. My daughter got hit by a 300-pound live woman. Yesterday, we had a tournament in north of Napa, and she said everybody saw her shoulder go flying. I was grading laughing down, so I didn't see it happen. I was there, but I was grading. And so the coach, was yelling at her, "Are you okay?" She's like, "Fine, it didn't even hurt." She spent the night at a friend's house last night working on homework, or the night before, and she said now she can't move her arm across her chest. And so I said, "Do you want to see the doctor's appointment?" And she's like, "Well, let me see." So we'll see. But she was crying out. They had conditioning for 3 weeks before the school year starts, and so she was at conditioning and stepped in a hole out in the field and twisted her knee, and so I took her for x-rays, and she'd always said she didn't want to be tall. So I pulled the x-rays out when we left the radiologist's office, and it was of her knee, so I can see the top of her tibia and the distal end of her femur. And I said, "Well, honey, you're not going to grow anymore," because there were no black lines, and she burst into tears. And I was like, well, you told me you didn't want to be tall. She said, well, I wanted 2 more inches. So she's 5, 5 and a half, maybe 5 3/4 if you measure her right. And I said, you may still have, some growth left in your, up at the top of your femur or the bottom of your tibia, but right here at the knee, you're done. I would have been a little more gentle with her if I'd known she wanted 2 more inches. I thought I was giving her good news. But her feet haven't grown anymore either, so which is a good idea because she tries to wear my shoes and stretches them out. All right, so when this disappears, it leaves just a kind of a almost hard to find line in the epiphysis, so that's known as the epiphyseal line. So the epiphyseal line is trabecular bone tissue with kind of really close together, whereas the epiphyseal plate is hyaline cartilage. Just check.
Looks like you're only on one end of the bones. Is the epiphyseal plate on both ends or just on one?
It is on both ends. So on this one, it's just happened to have closed already. So on some of these, like this one here, it's closed on the distal end. On this one here, it's closed on the proximal end. So it's going to vary. Yeah. All right, so bone tissue, when we were talking about function of bone, we said that one of those functions was to store minerals. Okay? Calcium and phosphate being the most important. And the body's other 2 tissues that we haven't talked about, muscle and nerve, have a higher priority as far as where that calcium is going to be used. So if the body's blood levels of calcium are low, the body will take the calcium out of the bone, okay, if you're not getting enough in your diet, and to provide it for muscle and primarily for nerve function. So we have, that's a better picture than I drew this morning. You guys are lucky to kind of work things out for them and then know what I want to do. All right, so obviously growth hormone is going to maintain the chondrocytes, but as far as calcium regulation, the 2 major hormones come from 2 organs that are found right here, just in front of your voice box. Okay? One of them is known as the thyroid gland. You guys have heard of that, who are hypothyroid or hypothyroid, the thyroid hormone. But this is a different hormone. And then behind it, on the posterior surface, are 2 small, 4 to 5 small. So thyroid gland makes a hormone in addition to thyroid hormone known as calcitonin. You can see what that has to do with calcium. And then on the deep surface, or posterior surface, so this is the posterior view, not inside the gland, but you know what shrink wrapping is? So kind of shrink wrapped against the surface of the thyroid gland are these parathyroid glands. And really difficult to remember their name, parathyroid hormone or parathormone. And these have opposite effects. Okay? Parathyroid hormone is going to increase osteoclast activity. So what's that going to do to calcium levels? Calcium is deposited between the collagen fibers. And as the osteoclast lysosomal enzymes degrade the collagen, it's going to release the calcium. So calcium phosphate levels go up, right? So its role is to also increase calcium concentration in the blood. Calcitonin, even though it has the word calcium kind of in its name, has the opposite effect. It's going to increase osteoblast activity and increase the amount of calcium added to the blood, so it's going to decrease blood calcium concentration. can't do without. Okay. So I had a friend, a colleague, who was just having his normal physical, and when they did blood tests, they noticed he had really high calcium levels. And they asked if he was having muscle cramps. He said no. And they said, well, you soon will if we don't do something about it. And they tested, and he had 2 of his parathyroid glands were cancerous. So they went in and took them out. If they had all been cancerous, they would have had to have left at least one or part of one behind, because there's some research developing artificial parathyroid hormone, but it's not far enough along yet, and you will die without the parathyroid glands. Okay? So even though they would, they keep checking them and maybe keep removing some tissue if it kept growing, but they would have to leave some behind.
Is that what calcium channel blockers are for?
Calcium channel blockers are most effective for the heart,
Oh, okay.
because calcium in muscle causes contraction. So when they're trying to decrease blood pressure or modify heart rate, they'll use it for that. Okay. But that's calcium, that's where calcium's role in muscle. In nerve, it is necessary for the neurotransmitters to be released, the chemicals at the end, but it also, well, we'll get into it, I don't want to get, it has other effects too.
So the pulsatile and
It's released by the thyroid gland. Different cells in the thyroid gland and make the thyroid hormone, but it is released within the thyroid gland. All right, let's just wrap up here with talking about bone fractures and healing. So I have some images here of bone diseases before we end up with the fractures. So osteoporosis is generally more prevalent in women than in men for a couple of reasons. What's the most obvious reason? Estrogen levels. So estrogen is a bone cell stimulus, as is testosterone. And men continue to produce testosterone, even though in less amounts, for a longer period than women do. So after menopause, estrogen, the ovaries are not actively synthesizing estrogen. And so our balance between osteoblast and osteoclast activity is decreased. Okay? What's another reason that men would have less of a problem with osteoporosis than women? Stress. And what causes stress on the bone? Weight. So the denser muscle mass, even the bone, is going to stimulate osteoblast activity. So I told you guys about my mom, and with her additional weight, she is stimulating her osteoblast. Okay? Reminds me, we were sharing backward compliments, moms and I, at this game yesterday, and one of the women was talking about a friend of hers whose mother told her, her mother-in-law told her, well, you're still never going to have to worry about wrinkles because you're so fat that your skin won't get wrinkled. So I'm like, well, how do I take that? But the extra weight does stimulate the bone osteoblast activity. All right? So my mom, who's older than by about 20 years than my grandmother was, when she developed osteoporosis, doesn't have any problem with it at all. Okay? So that's why in older women, or anybody that's getting close to, I mean, this starts happening in your 30s, all right, where you start losing some of this bone mass. So swimming, as opposed to running or jumping off of boxes, which is, I'm not sure, I mean, it's something that they do, I guess, and jumping up and down. That's putting stress on the bone tissue. Whereas swimming, while it's great for your lungs and your heart, isn't very good for your bones, all right, because the water's supporting the mass of your body.
what does someone's race have to do with osteoporosis?
It has to do with levels of hormones and how rapidly they change. So it's a metabolic. There are different races will have, there are a whole bunch of different things will be different. Cholesterol levels will be different based on liver functions. So it's the genetic expression and when those cells start to change. All right, so this is kind of looking at the trabecular bone and the vertebra of a male, middle age, well not quite middle age, and an older female. So when someone says, yeah, my grandmother fell and broke her hip, at that age, I think we have a case study on a fractured hip. It's actually a case of the bone breaking first and then falling. Okay, weight of the person with this type of bone tissue can cause a fracture before they fall. Paget's disease, basically I just want you to recognize that as a case of abnormal deposition of woven bone. So the normal places where we find woven bone is developing bone, all right, which is first being laid down in the embryo. As we'll see in just a few minutes, in a bone fracture. So when the bone is healing, the first bone that's laid down is woven bone. In other words, the collagen fibers are not neatly organized. And then another normal place for woven bone is in the joint between the teeth and the jaw. So anchoring the roots of the teeth is woven bone. All right? But in Paget's disease, there's a whole bunch of other aspects to it. It's almost like a bone tumor, but of an unorganized bone tissue. And in osteosarcoma, this is showing increased area of activity in the bone, can become malignant. It's a tumor, cancerous tumor of bone tissue. You've heard of adenocarcinomas and then sarcomas. You guys know the difference? It's the origin of the adenocarcinoma. The cells that are cancerous have an epithelial origin. They find those keratin proteins in it. Sarcomas are tumors of bone or muscle. All right. So let's finish up here with fractures and then a couple of steps in how they heal. In your lecture notes, the images for avulsion and impacted are flipped. So you just kind of draw a picture of that. So just a simple break. Who was telling me? Somebody, is this class or sexting? Someone was telling me when they were 12, they were lying on a couch and they had a pillow over their arm and their brother came along and jumped on them. Heard a snap, that was you, okay. Sorry, I didn't mean to. And so that was, did it tear the skin? You probably didn't see that it was torn. All right, so that would most likely be a simple fracture where there's a clean break and not much soft tissue damage around it. It can still be a clean brace in the sense of a clean broken surface, but if it's bent, then we start tearing the surrounding soft tissue and through the skin. That's what makes it compound. So it's not so much the bone break itself as the damage in the open wound, which can lead to infection. That's the difference between a simple fracture and a compound fracture. Can. Green stick would have been probably just a simple fracture, except that the bone is usually young. All right, it's not mineralized completely, and like taking a twig off of a tree and trying to break it versus a dead twig on the ground, it doesn't snap easily, and it starts to splinter on the surface that stress is being placed under it. And then that splintering causes additional soft tissue trauma. Okay? And that can also break through the skin, but the green stick specifically is not usually a break all the way through the bone, and then a splintering of the surface against which the stress is placed. A comminuted fracture is more pulverized bone. All right, so someone gets hit by a car and pinned against a brick wall. Instead of a clean snap, it's broken into multiple pieces. Okay? Impacted, this is what happens to somebody that parachutes out when their parachute collapses, or they jump off of a 2-story balcony and they land on their foot, and that's just going to jam one bone up into the other. Okay? So a telescoping inward of a bone into another. Avulsion can be spelled with an A or an E. This happened to my husband, was playing softball, and he had just gotten contacts. When you get older and your eyes don't change shape as easily, you used to wear bifocals, so that you could read up close and see distance. So my husband and now myself, I have a contact in this eye for reading up close, and a contact in this eye for distance. And my eyes switch. So right now, I can look at the distance structures, and I can read tiny, tiny, tiny print. If I go like this, I can read just really the top E. Maybe, and my eyes need to be changed. This way I can read E, F, P, T, O, Z, L, P, O, and then it gets a little fuzzy from this distance. All right, T, B, S, F, something like that. So, but what I've lost is depth perception, because this is seeing something in a different focus than this. And so he was going after the ball, and he missed, because it was coming at him, and he didn't get the proper depth perception. He missed the right angle to catch it and threw himself for a diving catch. And the strain of the angle that his hand went back, remember the Sharpie's fibers we talked about? And the ligaments just pulled a piece of his radius right off of the bone. So avulsion means to pull out by the roots. So that's essentially what happens to the bone. Rather than just breaking, it gets pulled apart. Okay? And so that's the impact. Remember I said the diagrams are flipped on those two. A spiral, if someone goes, especially a child, goes into the emergency room with a spiral fracture, that is a really strong signal to investigate for child abuse. Because that is done by taking the arm, the forearm, and just twisting. Okay? So it's not all, it's usually not a clean fracture all the way through. It's more, what I want, a crack, but in a spiral formation. Okay? And so you can do that to yourself. You fall out of a tree and the momentum swings you around while you're still holding on. Okay, but especially in a child, when they see that, they're going to check for family histories, hopefully at least, they're supposed to, for other evidence of healed fractures or partially healing fractures in the child if they come in with something like that. Okay, now, how does bone heal? Just real quickly here. So when a bone is broken, the first step is the inflammatory phase, just like we saw with a wound healing. And the major, remember how the fibroblasts created the collagen fibers for the granulation and filling in of the wound? So here, fibroblasts that are in the periosteum multiply and make lots of collagen fibers that fill in the gap between the two broken ends of the bone. And then stem cells that are present in the area, instead of developing into fibroblasts, develop into cartilage cells. And the irregular, dense irregular connective tissue is converted to fibrocartilage. And that creates a lump that kind of knits those two bones back together. And from the inside and from the deep surface of the fibroblast, then osteoclasts will gradually remove the fibrocartilage and osteoblasts will lay down bone. And that will keep occurring until finally we have complete bone tissue. That might get smoothed down or it might leave a bump. Okay? So when my son was born, my youngest son, I may have mentioned, I forget when I do this at which school, he was born with a cleft lip. Instead of from here, it was at the side of his mouth. Okay? Not only part of embryo development, the face develops into what are called brachial arches. And one of them involves the formation of the lower jaw. So this particular condition can affect hearing. 99% of the kids are deaf. They can have eye problems, they can have heart problems, missing kidneys, missing parts of their lungs. And he was perfectly fine, except for what you can see visually. His larynx is tilted slightly forward, but other than that. So he was born with a smaller jaw. So that only became visible as he got older. And then cartilage from his ear grew out into his cheek. So it was like finger tags. You could actually feel cartilage in there. And we had his hearing tested when he was 2 or 3 days old. They put an adult-sized headphone over this 5-pound, 9-ounce baby. And sent sounds and then measured the vibration of the eardrum in response to that. And he had normal hearing. Within 2 months, he had lost 50% of his hearing. And that was because the ear tube that connects to your throat, the eustachian tube or internal auditory tube that allows us to equilibrate balance, was collapsed. The muscle wasn't working very well. And so the air in his middle ear was reabsorbed and replaced by fluid. So it's just like being in the water, your membrane doesn't vibrate. I had taken him to a hearing doctor to have his hearing tested. born September 20. This was end of October, middle of, beginning of November. And I was checking out, and I heard this woman behind me say, "What in the world happened to your baby?" And I turned around and I said, "Well, he was born like that." And she said, "Well," she said, "it looks like someone was carving a pumpkin and the knife slipped." And as soon as she said that, the receptionist's eyes just went, and everybody in the waiting room. And as soon as she said, I was fine, because it's like, there's something wrong with her. You know, normal people just aren't going to talk like that. So I was actually dealt better with it than everybody else that was there. And growing up, playing in the playground, you know, kids would stare at him a little bit, but he has never ever been teased about his face. Surgery at 7 months to close the cleft and to remove the skin tags. He has a nice Harry Potter scar. He's very proud of his Harry Potter scar here. That it decreases the tension. He had 100 stitches. He's had the surgery. And perfect dentition until his adult teeth started to come in. And they go every which way. So the procedure when he was born for the jaw was to wait until you had an adult face, so 17 or 18, and then cut the skull and cut the jaw and increase its ability to grow. I'll talk about how in just a moment. But University of Michigan was starting to do it when they were just 3 or 4 years old. So they decided to wait until his second molars came in. And then when he was 11, he had surgery, and they cut the mandible on his left side just right here, behind the second molar. And placed steel plates on either side, and then connected that with a rod, about 1.5 millimeters diameter that came out through his skin. And then at first twice a day, and then 3 times a day, I took a 6-sided wrench and turned it 1 to 3 times. What that did was the bone was cut, and then each time I turned it, it spread the bone apart. So this whole process started occurring with the cut bone. And fibrocartilage was filling in cartilage, fibrous tissue, and then fibrocartilage. And they gave me codeine to give him. He didn't even need Tylenol the first 2 weeks. It didn't hurt at all. We were at the doctor's office the first time, and my husband and I were just petrified to see the doctor do this the first time. Beginning of the 3rd week, he had been fine. I went to turn the screw in the morning, and he fell to the floor just screeching in pain because the bone deposition had started taking place, and I was tearing that as I was spreading it. And so I had to give him double the dose of codeine before I did the procedure. I ran out of the bottle in like 3 days. I had to get another prescription, and he was sleeping during school because he was so medicated with codeine. And we were supposed to move the jaw, increase the jaw by 33 millimeters, and we did 28. About 24 is an inch. So we got it to spread slightly over an inch. So his left in 3 weeks. His left jaw was short like this, and what we did was moved it like that. And so as this side won't grow. So as this side grows, it's coming back like this. And he needs the procedure done at least 1 more time. So this was actually developed in Russia for people who were victims of nuclear accidents that the energy killed the chondrocytes. And so they were had short arms and short legs, and it was developed for the humerus and the femur. And they could get 4 inches of growth, elongation, in 6 months. Wow. And they now do it across the 2 bones of the forearm or 2 bones in the leg. Okay. And it's basically making the bone react as if it was broken and filling in to heal that space. Before he had the procedure done, I was looking it up online because I was trying to show something to explain it to him. And I found a couple of cartoon videos, but he didn't want to watch them. And then I saw a show where there was a young boy, and some babies are born with both sides of the jaw are really receded back to here, so their face is like that. And they'll do it in infancy if it's so short they're having problems breathing. This kid was 5, and they wanted to do the procedure before he started school. so he wouldn't get teased. And they brought him to the States, and instead of just the jaw, they did the entire face. So they cut all the way around here like this, and then pulled the whole face forward. And I was so glad that Will hadn't watched that, because the poor kid was moaning before he even came out of anesthesia. I was like, okay, well, you don't need to see this, Will. But I just kind of explained it to him. So that third week, he got promised a cockatiel, a skateboard, all the ice cream he wanted. But he still remembers it enough, and he knows that in the next, couple of years, he's going to have that procedure again. But it was just that last little bit that was where the knitting bone tissue was forming. It was actually, because we were re-breaking it almost every time that we did that. So this is, on this issue, it's done, it's controversial. Short people have their own culture like deaf people do. And so when a person is deaf decides to have a cochlear implant, they're often looked as if they're betraying other deaf people by leaving that particular culture. And the same thing with short people or dwarfs, if they decide, I want to be of a normal height. And there's different kinds of dwarfs. There's people that are short and everything is proportional, or they're short but their head is too big for the size of their body. So it can be different causes than just lack of growth hormone. But this is one of the procedures that they can't give them growth hormone if the growth plate is already gone. Maybe not normal, but instead of 3'2", they could be 4. It's controversial, but it is a procedure that's out there. Or if one leg is born shorter, one leg shorter than the other, or something like that. So then the controversy becomes like for his, we couldn't get insurance. We don't get orthodontic insurance through the college district, and so we had to pay out of pocket for all the dental work. Even though the insurance covered all the medical stuff, that was considered to be dental. It's like, wait a minute here, we're moving the teeth so we can do the surgery. It's like, no, that's orthodontics. Insurance isn't going to cover it. So about 2 summers ago, our orthodontist actually testified in the passing of a bill that tried to clarify when it was truly a medical dental condition versus too much of an overbite. Because the dentist will say, well, it's all medical, none of it's cosmetic. But there are certainly cases where, you're changing the whole structure of the bone of the face rather than just straightening teeth kind of thing. And so that's kind of what we're waiting for, is to get that ironed out so he can have his second procedure. He needs to have additional orthodontistry for that. Okay, so we'll stop here. Your lab quiz on Thursday will deal through the bone growth. So be able to identify the zone of calcification or the reserve cartilage, osteoblasts, endosteum, concentric lamellae, diaphysis. So that will be, when we come back from break, we're going to start going over the skull, kind of a combined lecture lab. You'll have the skulls in front of you, and I'll kind of talk and move around the room and help you find it, but the skull will not be on the quiz. Okay? So why don't you take a break until 20